In critical care, nutrition support is vital for patient recovery. Evidence-based strategies focus on individualized nutritional assessments, ensuring caloric needs are met, and monitoring for complications. Enteral nutrition is preferred, but parenteral nutrition is considered when necessary. Multidisciplinary collaboration is essential to optimize outcomes and improve patient prognosis in the intensive care unit setting. In critical care, nutritional support is vital for patient recovery. Evidence-based strategies focus on optimizing caloric intake, protein requirements, and monitoring. Enteral nutrition is preferred for maintaining gut integrity, while parenteral nutrition is reserved for specific cases. Pharmacists play a crucial role in ensuring safe, effective nutrition therapy, preventing complications, and enhancing patient outcomes. Nutrition in the intensive care unit is crucial for patient outcomes. Optimal timing and composition enhance recovery. Differentiate enteral and parenteral nutrition by understanding their indications and contraindications. Review timing, targets, and monitoring to apply guidelines for caloric and protein needs. Pharmacists play a key role in safe nutrition therapy, optimizing delivery and preventing complications. Nutrition support in the intensive care unit is crucial for preventing malnutrition and muscle wasting, maintaining lean body mass, and supporting immune function. It reduces infection risk and intensive care unit stay, with evidence showing a 25–30% reduction in nosocomial infections. Early, adequate nutrition improves survival, with meta-analyses highlighting significant mortality benefits from protocol-driven interventions. Enteral nutrition, EN, is the preferred route when the gastrointestinal tract is functional. Initiate within 24 to 48 hours of intensive care unit admission, following American Society for Parenteral and Enteral Nutrition Society of Critical Care Medicine guidelines. Continuous feeding is favored to reduce aspiration risk. High-protein formulas are essential for critically ill patients. Monitor for intolerance signs like gastric residual volumes over 500 milliliters, vomiting, diarrhea, or abdominal pain. Parenteral nutrition, PN, is essential when enteral nutrition is not feasible, such as in severe pancreatitis or short bowel syndrome. Delay parenteral nutrition for 7 days in well-nourished patients, but consider earlier initiation in malnourished individuals. Monitor for central line infections, hyperglycemia, and metabolic complications, as these risks necessitate vigilant oversight. Energy and protein targets are crucial in nutritional support. Aim for 20–25 kilocalories per kilogram per day to prevent overfeeding, which can exacerbate respiratory failure and hyperglycemia. Protein needs are higher in critical illness, ranging from 1.2 to 2.0 grams per kilogram per day, to preserve muscle mass. Use indirect calorimetry for precise adjustments when possible. Micronutrient management in parenteral nutrition is crucial. Multivitamin and trace element supplementation is mandatory. Administer thiamine 100–200 milliliters daily to prevent Wernicke encephalopathy. Adjust electrolytes like sodium, potassium, magnesium, phosphate, and calcium based on serum levels, with phosphorus monitoring to prevent refeeding syndrome. Consider omega-3 in acute respiratory distress syndrome or sepsis. Avoid glutamine in renal hepatic failure. Daily monitoring of nutrition therapy involves checking electrolytes through a comprehensive metabolic panel, maintaining glucose levels between 140–180 milligrams per deciliter in critically ill patients, and assessing fluid balance via intake, output, and weight trends. Weekly monitor triglycerides with lipid-containing parenteral nutrition, liver function tests, and prealbumin or transferrin trends to ensure effective nutrition management. Pharmacists play a crucial role in nutrition support by ensuring Y-site compatibility of parenteral nutrition with medications and monitoring phenytoin absorption during enteral feeding. They calculate and adjust electrolytes and micronutrients in parenteral nutrition formulations, develop insulin protocols, and train intensive care unit staff on safe preparation and administration techniques, enhancing medication safety and quality assurance.